and learn a bit about the work that you're doing.
Thank you. Yeah, so for those of you who don't know me, I'm Neeraj Soni. I'm one of the emergency physicians at St. Luke's. Been there since 2001, and shortly after I got there, I started getting assigned and then eventually embraced the role of being our electronic health record guy. I got here in September of '01, and we had just implemented with Gary's help, we'll call it help, our first electronic health record for the emergency department at St. Luke's. And so then in that role kept in sort of connected to that work. And then a few years ago, we moved to Epic as our system-wide medical record, and then I took on the job of Chief Medical Informatics Officer, which basically means at the physician executive level, the person responsible for how we use our technology to provide clinical care. We really focus on the bedside use of technology. I still work in the emergency department part-time, about 5 to 6 shifts a month. I didn't bring slides, as you can see, today. I thought we can just have this be a really informal discussion, mostly guided by the kind of questions you guys would have and topics you want to cover. I just have a couple of different things to talk about up front, and then we can take the discussion from there. So AI is super popular as a buzzword right now. If you're trying to sell technology to a health system and you can't figure out how to include AI in your brochure, you shouldn't even bother showing up. So everybody has something AI related. We don't have a really good sense of what I is to begin with, right? Like really understanding like what is human intelligence is a pretty fuzzy topic, and so figuring out what artificial intelligence is and where is the line between artificial intelligence and real intelligence is more or less unanswerable. It's hard to tell the two apart. One of the things that's changed in the last few years, and the reason why anybody connected to healthcare at all is taking an interest in this, is the generative AI, where these programs and softwares are creating new content that didn't exist before. And that feels different. And it can be harder to tell when something that you're interacting with or consuming is generated by one of these programs, or whether it was generated by a human. Getting back to that AI versus real intelligence question, though, I think part of the reason why it's so hard to tell is that for a long time now, on the internet, where there's a lot of content being created, and there's a lot of people who are paid just to create content, the quality of that content has gone down overall. And so even before ChatGPT started producing AI-generated content, there's plenty that was out there that sounded like it was written by somebody who doesn't really understand what they're talking about, which is what ChatGPT is, right? It's a model that does the equivalent of, that old sort of example that we all grew up with, of a monkey with a typewriter given enough time could spit out Shakespeare. That's what this is, right? It's all probability, right? Probability that the next word that gets put down on the screen is the right word. It's just that the computers are a lot faster. So you don't have to wait a million years to do it. But that's not understanding, right? That's not real creativity. It looks like it. And that's where we have difficulties, figuring out what looks like something that's creative and what actually is creative. This is the part of AI that's gotten the most attention, is creating this type of content. But it's not the area that'll end up having the biggest impact in healthcare. I think that there's a lot of uses in healthcare that are already implemented and many that are getting evaluated now that actually do something in a new or different way that we just can't do as humans. So they're more like, think of like flying, right? We can't fly, but we can simulate it by getting in an airplane, and that's a great advance. So some of the technology that uses AI is helping us do things that we just physically weren't capable of doing before. To jump in with an example of something like that, we're evaluating at St. Luke's a program that uses information, images from cardiac CTs, which is, again, something that we don't even do in the emergency department right now. None of you did when you're practicing, but in the right clinical scenario, they're becoming the standard imaging test for patients. And what you today get with a cardiac CT, the output that's clinically meaningful is a calcium score, an assessment of how much atherosclerotic disease is there in the coronary arteries. You can't do CAT scans on moving objects, so the patients are going to get a beta blocker, and this CAT scan happens fast enough that the motion artifact is minimal. So that's a pretty amazing technology in and of itself. What the AI tools do with that information is that if you send them, so you're transmitting this image now electronically, it can analyze the image to actually give you information about perfusion, not just the calcium score. So how would it do that? Well, probably the same way that a human does it, but better, right? So radiologist looking at an image is looking at dark spots and light spots, and the dark spots and light spots mean something. And our ability as humans might be limited to this area looks really dark, and this area looks normal, and this area looks kind of in between. Then the software can give you all of the gradations in between that. And so it can actually give an estimate of what this patient's myocardial perfusion might be based on the CAT scan, not an additional test. So what do we do with this information now? We don't just automatically zap them and put a stent in, but that's a better screening tool for figuring out who needs an actual CAT rather than just Gestalt or what day of the week it is. So that's the way that the AI makes us better care providers, right? So we get patients who might benefit from a cardiac cath into the cath lab, and we get patients who might have atherosclerotic disease, but no indication of decreased perfusion, and they don't need to be in the cath lab, so we'll keep them out of the cath lab. We don't have that yet at St. Luke's, but decent chance that we'll have that kind of technology. We already have a tool called Rapid AI, and Rapid AI is a neuroimaging software, so that when patients come in with stroke symptoms, we get a CT of the head to figure out if they are going to qualify for thrombolytics, and we get a CT angiogram to figure out if they have an actual clot in a vessel large enough where the neuroradiologist can go and retrieve it. But they don't want to retrieve clots from areas of dead brain. They want to retrieve clots from areas of at-risk brain. And what we have with Rapid AI, we don't have neurointerventional radiologists reading the CT primarily. We have the neuroradiologist doing it. But the interventional radiologist is the one that's going to have to come in and do the procedure. So in order to speed up that process, we have them receiving this AI-enabled image at the same time that it's collected. So they receive it on their smartphone through this app. And so they'll know that this patient that's currently getting a CT angiogram and has a macroembolus, whether this is going to be a good candidate for reperfusion. So they can often initiate the phone call to start that consultation process even before the image interpretation is finalized. That's already in play. There are You know that we have healthcare provider shortages in the country, but we also have all of the ancillary services are understaffed as well. And that's a huge limitation on our ability to provide more care to more people, like we're being asked to. And this is another area where AI is being utilized. So in our sleep labs, patients will go in for a sleep study, and it's video monitored. And at some point, a technician has to go through the images and essentially code them, or we call it scoring. So they're going to be looking for restless movements, for signs of waking, arm movements, leg movements, turning over, all of those things. And basically just document those from the sleep study. And that end result now will go to a sleep specialist to make a determination, offer treatment options, those kinds of things. But it's a rate limiting step right now to get those studies scored. So it's hard enough to get into the sleep lab to get your test. Once you get your test, you're not going to get any information out of it until it's been scored and then sent to the sleep specialist. And there are not a lot of sleep lab techs being produced. Yet the number of sleep studies that need to get done is increasing. What do we do about that? Well, that's where AI comes in. So there's a tool marketed now, so it's in production. It's not, we don't have it yet at St. Luke's either, where the software will take that video output from the sleep study and provide a preliminary score. So it's interpreting these images. The images are all equal to them, right? So the AI tool doesn't know that it's a person or a bed or a piece of artwork on the wall, right? It's just all pixels. But that's where the computing power comes in to figure out, here's the area of this image that's of interest, and this is what it looks like when there's restless arm movement and restless leg movement, and this is what it looks like when someone is turning over, and this is what it looks like when someone's falling out of bed, and provides scores for that. The tech now has a much simpler job of reviewing that score and verifying it, and then sending it on to the sleep specialist. So in this example, having the AI enables us to not hire, we still need the sleep techs we have, but it enables us to not hire the 5 more that don't exist. And that's a key part of how this technology is being used. The area that's most exciting to the practicing clinician is the AI-enabled documentation. And we're doing this, just completing a pilot of this at St. Luke's and moving on to actual implementation. There's a number of vendors out there that do this. So it's voice recognition and recording based. So whether it's on your desktop or smartphone app or on a phone that the organization might provide, the software is listening to this interaction between patient and physician or APP and producing a document from it. So as a physician, you can have the same conversation that you've always had with your patient. You talk about how their grandkids are, where they're going on vacation, how their golf game is going, and then spend some time talking about how their diabetes management is going, and whether they actually started the medication that they're supposed to start, whether they're having any side effects. Come back and ask them about how their spouse is doing, and then finish up your visit with some instructions to the patient. Here's what I want you to do differently. Here are the things I want you to watch out for. Here are some diet changes to make, and we'll see you back in a year or 6 months. And the output that's produced from that is not a transcript. The output is actually a interpretive document of that visit. So it takes out all of the vacation talk, all of the grandkid talk, and leaves in the medical part. And it does it astonishingly well as an actual human scribe would, and probably a little bit better than we would on our own. Because for us, the act of documenting takes time and effort. For the AI tool, it doesn't. And so we might want to pick like 1 or 2 or 3 things that were important out of that list. The AI tool can put them all in and let us choose what we want to take out if we want to take out things.
So you speak and it just records and comes out in your printer?
It will come out, it comes out on the screen, and then you can take that extra step of editing it right where you see it, or you can transfer that to the actual visit note and edit it there.
How does it work? I mean, a lot of times you're talking to a patient. Typical example, a new patient, couple comes in, you ask the gentleman if he's having any chest pain, he says, no, I'm fine, and his wife is behind like this. I mean, a lot of the information that you gather during a good history is nonverbal.
Right.
How does it implement that?
It doesn't implement anything that's nonverbal. But if you take those nonverbal cues and then have follow-up questions, it'll pick that up. But you're right, it's purely dependent on what's said out loud. And that's one of its biggest limitations. This is right now, it's primarily being used in the clinic settings, ambulatory clinics and primary care clinics, and they're gradually building out the models for specialties, because it is really not a one-size-fits-all tool. So how this model works for a primary care doc, and how it works for a cardiologist, and how it works for a pediatrician, and then how it works in behavioral health are all different, because the type of content out of that conversation that needs to go into the note is different in those different scenarios. So I've tried it in the emergency department as we're doing this pilot, and the problem for me is that most of what goes in my note is not verbal, wasn't expressed verbally in my interaction with the patient. There's the HPI, it does a good job of that, but the bulk of my note and the place that's highest risk is all of the medical decision making that had to happen. And some of that I'm going to review with the patient at the end, but most of it is stuff that I had to think. And if I had to think it, now I have the option of either telling the AI what I thought and then editing what it produces, or I could just use voice recognition and tell the EHR what I thought directly. And so that right now, that's a lot easier for me. And so that's what. So there's still work to be done to see how it would apply in the emergency department. But in a clinic setting where the bulk of the interaction happens in one block of time, and then you're done with that patient and you go on to the next one, you can get from the subjective evaluation to the patient instructions all in one recording. And the program is designed to break that up into the appropriate different sections.
Is this real time? So when you leave the office, that knows done?
Yeah.
And is the goal to or thoroughly capture that visit, or to do some risk management, or to document stuff for billing? And what's the goal for the use of AI?
Yeah, so in that context, the goal is whatever the organization wants to make the goal. And so the way we're approaching this is that the goal is to decrease the burden on the physicians and APPs involved in providing care. That's the fundamental goal. And to that extent,
Just because documentation is such a pain.
That's right. That's right. So if we can make your day a little bit easier, then that's a good thing for you and for patient care in general. That's the way we're approaching it at St. Luke's. All of the other things you said are also applicable. And so there are organizations that are also looking at this, but they're looking at it from their interest in implementing it will come from a strict ROI lens. And so this is great. It costs several thousands of dollars per person per year. And so we're going to recoup that cost by putting 2 more people on the schedule. And that's not unreasonable. It's just not the way that we're doing it. We're not saying that, hey, we're going to help with wellness and at the same time increase your burden and try to make that as an offset.
I was going to ask that exact question of, is this, oh, now you can see 10 more patients because it's so efficient.
Yes.
It's like, how about just giving back my time after clinic that I'm documenting, and not asking me to do anything more like it used to be, right?
That's how we're approaching it.
That's great.
The other parts of it, though, so you could see more patients, and some people will. Some people really will want to see more patients because they have the time to do it. For the patients that you already were seeing and the conversation you were already having with the patient, it does a better job of documenting it. So just like I was saying that we could, when we're documenting as humans, I want to pick the 2 or 3 most important things and put that in my note. But maybe there are 5 things that were important and 4 of them that were meaningful to the patient's overall disease burden, which impacts our revenue and value-based models. And this program can put in all 4 of them, or all 5 of them.
Has it been tested before? The AI didn't list this thing, and therefore you left it out of your note, and therefore?
No, there isn't any case law on it yet. It's a little bit too early. But yeah, eventually. But I think,
Don't wait very long.
I think I'm less concerned about that. Of all the different things to be concerned about.
Better job overall.
Right.
Than what we have today.
Yes, right. It's an improvement in terms of comprehensiveness. It's also, it can recommend coding for the visit. So based on the content, it can recommend which level of code to put in, which for, I guess I would say for the average mid-career physician right now, it's probably 6s because they've had so much of their career devoted to improving coding and coding accuracy.
A lot of coding is based upon time.
It's not really good at time.
No.
It's good at content. The time piece of it is improving, but it's not quite there now. You can modify it, right? So if you spend a certain amount of time.
I spent X number of minutes.
Yeah, then you can do that. It has, the tool that we're piloting and implementing has an automatic calculator based on the length of recording, but it doesn't capture it as well right now as it needs to.
As a physician who was in private practice and not a hospital based necessarily, my biggest frustration with the electronic medical records is that, so say a patient is being seen by a doctor or family doctor every 6 months or whatever. The reams and reams of useless bullshit that I get, which is cut and paste for the last 7 years, was ridiculous.
Yeah.
Can AI solve that problem?
So it can't solve the problem of people producing reams and reams of material that's all useless. It can solve the problem, especially if you're seeing a patient for the first time, of distilling what's important out of that. So that part is definitely useful, right? The problem with the reams and reams of information is that we haven't really adapted our documentation to electronic health records in a sense that in the old days, the note was the patient's record. And now the note that we produce today is a part of the patient's record rather than the whole thing. And we haven't really made that shift. So in a patient that comes into the emergency department who's been getting all of their care at St. Luke's, and therefore all of that information is right there in the patient's electronic health record, there's not a ton of value in me putting in the patient's past medical history pulled in via an automatic link into my note. Right? That's all duplication. I'm certainly not mentally processing every element of the patient's past medical history. I didn't type it in, which at least was some act of synthesis and acceptance that this is the patient's past medical history. I just pulled it into my note automatically. And the real past medical history lives in the past medical history section of their note. So it's only taking up space in my note, not providing any real value, right? It would be helpful if I documented what aspect of the past medical history is actually relevant to this visit. And that's probably already up there in the patient's HPI or in the medical decision making. That because this patient has this problem, we're approaching it in a certain way. But that's not the way that we've been taught and trained to document. So we're behind on that. And I don't see it changing anytime quickly because the documentation approaches that our medical students take is basically the same that we've taken.
I think the fusion of the medical record and what the basis for billing is the principal problem with why every last item is put down there because they can every time.
It's a little bit, but I think that part of it is also that I don't think it's all, I guess, malintent or non-clinical intent. I think people are actually trying to be helpful in putting the patient's last lab results and x-ray results and CT results and echocardiogram results in their note because they think that that saves the reader some time so that you can just read this note and get that information rather than going to the section of the patient's electronic health record that shows their last echocardiogram and last EKG and last labs, because it's all there. And there's some element of truth to that. The thing that's changed is how easy it is to pull in that content into today's note. So that it doesn't take me any effort to create a 10-page note. It takes me a lot of effort to create a 1-page note. Right?
So I think since everything's based on what is said between you and the patient, we're really good for the history part. It seems like that wouldn't work as well for the physical exam part. For instance, orthopedics, if I had to say out loud everything that I'm examining and feeling, and so that's going to create a tremendous amount of questions, and the visit's going to get enormously long. Or if so I can't say it out loud, everything I'm seeing or feeling with the patient, and if I then have to go and, after the patient's left, record all that, just like I did in the past without, it's hard to see how that saves any time as far as your physical exam findings, which are frequently a big part of what goes into decision making for that patient.
Yeah, the purpose of these tools or the value of the tools is not that it eliminates all of the time that we spend on documentation, but that it lessens it and makes the documentation time feel more valuable because it's stuff that only you know. So in that example, a couple of different ways that it's approached. So some people are able, in the physical exam section, most people who are documenting in the EHR use some sort of template. Right? If a patient's coming in for a shoulder issue, and then you might have a templated complete shoulder exam of one that might look normal, and it has all of the details that you would normally put in it, and then you start with that and go and highlight and change the things that are different. That's what's happening today. So in that environment, some people will change what they do, and so they'll say, "Well, I'll use my template, but I'm going to say out loud the things that are different from my template," and that might generate some questions from the patient. But the patients know that we're doing this, right? They know that we're using a tool, and often we just say that at the start of the visit too, that we're using this assisted device, and so I'm going to just say some things about the exam just so that it gets documented, and they will appreciate that. The other people might just say, it's easier for me to just make the edits on the computer and not use that element of this tool, and so not use it for physical exam at all, and only use it for the HPI part of it and for the assessment and plan part of it. That works too. Either way, it saves them that time.
A question, you touched briefly on price tag. It's one thing for the hospital employed physicians to have this rollout and all this cool stuff, but how about the guys in private practice? Are they gonna have to pony up X dollars for an AI system from St. Louis and Y dollars for the AI system from now or from whatever? What's the vision of kind of rolling this out, assuming it works okay?
So it all depends on what that independent physician's EHR is in their clinic,
Of the many, yes.
right? And so the AI tools are not being developed by the EHR vendors. So it's a different sort of adjacent industry.
So it'd be overlay on top of the EHR?
Generally, yeah. So they would have to
They
have,
have to pay for it
Yeah,
themselves.
yeah.
Because, I mean, you talk about frustrations, and I appreciate your frustration with paper, but the other frustration I have is, I have about 5 or 6 different kind of specialty people I go to, and every single one of them has their own thing that they want you to log into,
Mhm.
your username and password, and see your stuff there. It only talks to itself, it doesn't talk to anybody else. You could have this for the dermatologist, this for the orthopedist, this for the who's.
right. That's,
As, from a patient perspective.
the free market is terrible, right?
That's-
From the-
that's-
Yes, right, from the patient perspective, the free market is terrible. From the vendor perspective, it's great. But yeah, I mean, the more, if we had a single system, that's what it would look like. A single system means that you would log in on one patient portal and everybody's connected to it.
I don't know that it has to be a single system, but at least single systems that talk, you know,
Yeah.
as opposed to this silo thing that's been talked about for 20 years. And
Right.
nobody's communicating. I thought the best thing about this whole deal was lab and x-ray. And just, if that's all you had, was a capture lab and x-ray someplace and not lose it,
Yeah.
that'd be a big win. But that's kind of where we are today. I just, where do you see the AI helping the most? Is it just concentrating your thoughts and maybe condensing to a page and being actionable, or is it summarizing the 8 pages of law so that you don't have to print it or even capture it?
So I think if you look back at the examples I was going through, I think all of those are areas where the AI is going to help in different ways. So it's going to help by giving us capabilities to use data that we already have in ways that we either didn't imagine or just weren't humanly possible. And so some of that imaging AI fits into that category. It's also going to enable us to stretch out some limited resources and use limited resources as overseers of the AI product rather than having to produce it themselves. And so the sleep lab example fits into that category. And then the last part is this generating content and parsing out that content in a way that's more useful for clinicians and more useful for patients.
Do you see AI, you see it replacing most of radiology?
Not at all, no.
Just enhancing, would still have 37 radiologists to read.
Yeah, I mean, they're not making radiologists fast enough to
I know
manage the
they're
need.
busy, that's why I
Yeah.
get, if you get 90% of their work to be here,
Mhm.
and then there's that 10% to be this work, I could see routine chest x-rays could be just a slam dunk.
Well, so in the chest X-ray example,
And are they enthusiastic about that or not?
yeah, so for the most part, yes, because they also see 2 issues. One is the amount of things that they have to do is increasing significantly. So their ability to hire enough radiologists and also have enough of an expertise in all of the different medical imaging subspecialties is impossible because the expectations of the quality of their work and the depth of the analysis is also increasing. So that's impossible for them to meet on their own. Technology is going to be a piece of that. And then the radiologist, the human radiologist, is the one that oversees the product and the output. But even something as routine as a chest X-ray, what the AI can do better is find nodules and offer comparisons to the previous exam or comparisons to a chest CT and have the radiologist look at it and verify it. So even on the most mundane of studies, there's application of.
So they're enthusiastic about using AI.
Yeah, in fact, there is, and the amount of development in that in that niche is huge. The problem there for an organization like St. Luke's in any health system is figuring out how to pick and choose which product is going to make a meaningful impact. They tend to all be one-off products. So a product that is good at and approved for some sort of analysis on chest x-rays and chest CTs may not be approved or good at interpretation of abdominal CTs.
So there will be a constant evolution of technology. And you buy one product from a vendor, and 6 months later, a new product, a new flight, more Chrome comes out.
Right.
And so you're constantly playing catch ups. It's like when we, at first at St. Luke's, when we first got the first robot, it was amazing, and it was expensive. And then the next iteration came, and it was more expensive. Finally, they decided, okay, let's not buy it, let's just lease it. And let the company upgrade it and pay for the maintenance and everything. We won't buy it anymore.
Yeah.
So I've been around since you started EMRs, and it was extremely expensive. Maybe you know how much money St. Luke spent for it. And then St. Luke's got it, St. Al's got it, and then all the private practitioners had to get, all the small groups had to get it. So how do you chase that increasing cost?
That's complicated, right? And not always done very well. So we do like you would for any decision. Figure out the value, ask those same kind of questions. Is this something that we're going to be replacing very soon? Is this new tool provided by a new vendor going to be something that Epic does in a year or two? In which case we should probably not buy it from a new vendor and just wait. On the medical imaging side, especially as it relates to AI, we try to minimize the amount of change in infrastructure that we would need in order to use the new solution. Yeah. So if there's a new product there and it looks super valuable, but it requires a change in our IT infrastructure, we're not going to go with it, and we're just going to miss out on some of those opportunities. But yeah, they're not easy decisions. And the worst is that there's always potential that we choose something for its clinical value, and then the clinicians who would be using it don't, right? So an idle robot, for example, would be terrible, especially after all the time and effort that goes into evaluating those kinds of tools and then getting them approved and then getting them funded and then implementing them. So we're really trying to push that aspect of it, that this is really going to be meaningful. This is going to change patient care in a really meaningful way. Or, like in the case of these documentation aids, this is going to meaningfully decrease physician burnout, or it's going to pay for itself by having people push out their retirement date because now they enjoy practicing medicine more than they were. You see all of those things right now.
I would certainly support not increasing patient volume. Just say if you get done an hour early, go home an hour early, instead of, oh my goodness, you can see 3 more people.
Yep.
That would burn up even faster.
One question for you. You talked about how AI tools increase efficiency for what things we're already doing. The thing that intrigues me about AI is the data mining aspect of diving into the medical records to identify trends or things that might not catch a human eye.
Right.
Touch on that a little bit.
Yeah, so using AI to ask and answer the questions that we haven't even thought about, that is happening. I think that's a little bit harder when we think about the current tools out there, which are very much driven by prompts. And so we're learning this new capability of what they call prompt engineering. So how do you ask the AI the right questions in the right way to get useful output? Having AI pointed at huge data sets is definitely already underway. And way that what we do right now at St. Luke's is so we participate in an Epic network of data called Cosmos, and there are hundreds of organizations participating in it. So they send in unidentified data into to Epic. There are right now 250 plus million patients worth of information in that database with hundreds of data points each. And even today, that's searchable. You can do research off of this vast data set. What's difficult though is that in order to do the research in a way that's useful and reliable, you really have to know how the data got into that system, into Cosmos in the first place. So understanding the fields, understanding how they're labeled, understanding the nuances between different ICD-10 diagnoses, so you make sure you get the right ones that you want and all the ones that you want included.
You can't go back and recode stuff, so the coding is always a
Yeah.
mess.
Right.
You got 250 million data points, but code by this hospital, very aggressive coding, this was not so aggressive coding.
So right. And so that's what when you're submitting the data to Epic, there's a whole process to try to get similar data in similar fields from all the organizations. The place where AI is really helpful with that right now is that, the AI is not looking at the data set on its own and coming up with new insights. That's not there right now. What is there is that you can ask AI in natural language phrasing, and it will generate a formal data science-based prompt that it will use to query the database. And you can see it, right? So it doesn't do it in a black box. So you can just say, I want to know if we had more cardiovascular hospitalizations in the West compared to the East of the United States during certain fire seasons. And it will give you the prompt that it thinks will capture that data out of this vast data set. So the AI tools applied to data are, it's definitely an area of development. It has to be pointed to the right data set and actually have access to the data. And given the siloed nature of our data collection, that's a challenge. But this Cosmos data set is a huge trove of potential research.
I can see starting with the aggregate data, but I think the utility will be when you have individual patients that from which unseen questions can maybe be prompted by the AI engine and say, I don't know, autoimmune disease is suggested as a potential risk for this patient. Perhaps these are tests that you might consider. I don't know.
I think it's not that far away before that becomes an actual adjunct to clinical practice. It's not there quite yet in a useful way, but I don't think that's that far off.
And where would you see St. Luke's is in the world of this? Are we in the middle of the pack? Are we leading? Are we lagging as far as this whole effort?
I would say we're ahead of middle without being at the bleeding edge of it. We're trying to develop some organizational rigor around how we evaluate the new AI vendors and AI tools, and so that process is.
And about geography, is the west side of the country ahead of the curve versus the east, mid, south?
I couldn't answer that. I mean, it's definitely it's probably better developed in the west, just because that's. I mean, a lot of the tech development is centered in Bay Area, and that's true with a lot of these AI companies too.
And how expensive is it? I mean, is it, if I opened my office this morning and I said, I'm Joe Solo practitioner, internist, am I gonna say it's worth $100 a month? It's worth $1,000 a month
For what kind of tool?
for this, what you're talking
Oh,
about?
the voice recognition?
Helping me chart my patient visit.
Yeah, it still varies quite a bit, and so it can range from 5,000 to 15,000 a year for the individual person. But an individual person with no IHT department support would have a hard time doing it. So that's a big difference when we compare it to something like voice recognition. Which voice recognition, as an individual person, you could just go buy the software and put it on your computer and start using it really easily. These tools require some real integration and support to make them function correctly. So incremental cost, maybe between 5,000 and 15,000 per person per year, but there is some basic organizational maturity that's needed.
And there's not a vision of having an IT consulting practice out there to small groups that could do that work and bring it to them.
No, I'm sure there is. I'm sure there is.
And I just think about how much joy I got from charting my patient. Anything we can do to cut that down, you know.
The early response, 100 or so people that have had a chance to participate in this pilot implementation these last 3 or 4 months has been really positive, including some people who literally pushed out their retirement date because of it.
How many hours a week are you seeing, like, let's say, a primary care provider reduce in terms of charting?
That's an interesting question because the amount of time they reduce and the amount of time they feel they reduce are very different numbers.
Oh, interesting.
Yeah.
Which is more?
The amount of time they feel they reduce is orders of magnitude higher, or several times higher than the actual time.
Oh, interesting. So just the
But
perception.
it is
Yeah.
significant. I mean, it is saving them time.
Oh, I mean, so yeah, the last, it keeps evolving as we get more data. The last number I saw is that it reduced what it's referred to as pajama time, meaning off hours documentation, by about a third. So,
Yeah, I mean, if you can walk out of the office with the charts done and you've got 30 minutes of sunlight left, that's a heck of a day.
yeah, right.
That's a lot.
I was thinking December.
So you mentioned when you started, the patient, you say, I'm gonna use AI. And you see, some people say that, but some people don't. I'm just right now finishing my 8 hours of opioid training. And one of the biggest parts of it, it's hardest to remember, is HIPAA versus the other confidentiality. And is there a perception, I mean, patients saying that they use AI, is there a perception they say, that's Big Brother? I don't want you doing that, I don't trust that, or
Yeah.
how is that received?
That concern, I definitely figured prominently into our implementation. And it varies, I think, by where you are in the country, how much of a patient concern that is. The way, in our experience with this pilot, is that it hasn't been a big issue. So we didn't, and we don't require a separate consent. We do require, but don't document, a notification to the patient by the provider so that the patient has the opportunity to opt out and say, no, I don't want you to use that tool for this visit. And it says, then you press a button and stop the recording and you don't get to use that tool. But that hasn't really been a big issue from what I've heard. I think part of it is patient selection. So especially in primary care where you know your patient. So if you have a patient that you think it's going to take you more time and effort to explain the tool and whether it's safe or not safe to use and all those kind of things, then it would save you in documentation. Then don't even start the discussion, just don't use it for that patient. It still saves you a lot of time and all the others. So I think some patients have that concern. When I was trialing it in the ED, I used it about 100 times, and I didn't have anybody have any concern. with it. And so I'd have my phone out, they knew what I was doing. I was saying, I'm using a new software to help with my documentation. Is it okay if I use that? And so then I'll turn it on, so they know I'm using my phone. I think it's presumed that the phone is doing some kind of surveillance, right, to make it helpful.
Recording.
Right.
Was there any issues with recording, especially in the ER, or might be noisier than my office room?
A little bit, yeah. Not as much as you might expect, but definitely I saw some. And so the quieter the environment, the less likely it is to
What
miss
does
it.
AI do when they missed a couple of words or a couple of whatever? Do they put a blank and say fill it in, or?
No, it just fills it in on its own.
Okay.
Interpretive
Surprise.
documentation.
Your phone does that a lot of times too. if you're doing
Yes.
it.
Yeah.
Oh, yeah.
The difference with
Yeah,
the
very careful.
yeah, so if you think about the evolution of how we document, right? When we're doing it on paper, the problem with fidelity was that a lot of readers might not be able to actually read what you've written,
Because of,
handwriting.
really?
Yeah, it's weird.
Stunning.
Then when we started typing notes, you get typos. But typos are pretty easy to deal with, right? Then we started using voice recognition. Voice recognition doesn't make typos, but it will put in the wrong word.
What about in a real urgent situation, open chest wound thing, and there's 15 people in the room and they're all saying something and they're all shouting at each other and there's like kind of tech and doctors and everything. How does it differentiate what's going on?
The more people and the more chaos, the more trouble it'll have. So it does a good job in a quiet environment with multiple speakers and family members chiming in, nurse coming in to provide additional information about some other patient that has nothing to do with the current visit. It does a really good job with that, actually. But the more of that kind of chaos you add, the worse it'll get. And what I was saying earlier in terms of the evolution of types of mistakes that you'll see, so typos are easy to deal with. With voice recognition, it'll put in the wrong word, and that's usually pretty easy to deal with, but not always. Sometimes the misheard word
They're homonyms.
is hard to
Usually
replace,
other
actually.
stuff.
With AI, it doesn't create nonsensical sentences, but it might create inaccurate ones, just based on what it felt was probably the right thing to document or put down on the screen, but it wasn't.
So one other question, it may or may not have anything to do with what we're talking about, but when I retired 8 years ago, there was a huge surge of reps and vendors trying to sell a product where you did a genetic test of some sort on every patient, and it was supposed to tell you every patient what drug would be right for whatever diagnosis and the dosage.
Yeah.
And I haven't heard anything about it. So the last 8, did that die, or is that something AI could do, or is that even a thing that still is happening? Was that just a fad?
Definitely not a fad. And so there's some AI components to precision medicine, for sure, which is sort of the overarching term of what you're describing. But before getting to the AI piece of it, there's actual science there, and there are companies that are trying to help patients and health systems make use of that science. So yeah, those vendors are still there. Many of them have consolidated. We're evaluating tools that are available within Epic to help with that. But patients that get whole genome testing, whether the health system chooses to provide it or they go to an outside vendor or there's some partnership between health system and vendor, all of those are different ways to get the test performed. There is information now available to help with exactly that kind of decision making. So we refer to it broadly as pharmacogenomics. So which of these antihypertensives are more or less likely to help this patient? Same with antidepressants, lipid-lowering agents. There's a few broad classes of medicine that we know are more or less effective depending on certain gene expression. Not every medication, but a few that are really important. And then there are some where the patient's likelihood of adverse outcomes is affected by gene expression. And so if we know that information up front and can provide it to the prescriber, that patient does better. So it's definitely still there. It's a growing part of healthcare. We don't have that in an organized way at St. Luke's right now, but hopefully in the next 1 to 2 years, so not further than that, we'll be doing it.
It's maturing or it's matured and you just have to roll it out?
Both. It's maturing. It's mature enough to roll out and provide benefit both to patients and providers, but it's definitely maturing, and that's the AI piece of it on the research side.
I was curious, just, again, I have 6 providers, 17 providers, some phenomenal number, and none of them have ever said anything about this.
Right, I've never heard of a patient that's had it done, but boy, it was huge. I mean, every week somebody was trying to sell it to me, and I'm like, nobody ever do it, or does everybody have it except me?
No, it's there, and it's still growing, and I think that.
Is it oncology primarily, or is it
Well, oncology is where that precision medicine is used most actively right now. So, gone are the days where you get diagnosed with lung cancer or colon cancer, and therefore here's your treatment regimen. Right now, here's the pathology that's getting sent to specialized labs where they're doing specific gene expression from the tumor, and then that gene expression is what's driving the pharmacologic management afterwards. So that is the current state of things in oncology. What we don't have right now is having that information well integrated into the EHR, and that's developing. But that's pretty niche because you already know that you have a problem, and we're just talking about the best treatment for that problem. The whole genome testing is a different body of work where you take healthy patients and have their genomes analyzed. And on the oncology side and the disease side, those patients, based on their gene expression, may be more or less likely to have certain downstream illnesses. And what they are more likely to have, we should be more aggressive about their screening. And what they're less likely to have, we can just follow routine screening. So that information is available now if it's when it's fully implemented. So we'll see that, and as patients, we'll see that because we'll have that information in our patient portals as well, saying that here's the things that you're at increased risk for. Talk to your doc about whether you should have increased screening for those things. On the provider side, you can be ordering a medication, and just like today, you get a pop-up that says, well, this patient's highly allergic to this medication, you sure you want to give it? We'll have the same kind of information on pharmacogenomics. This patient has a high likelihood of having an adverse reaction. Here are some alternatives you could use for the same condition. So that the technology is there, the tools are there, and so at St. Luke's, what we need to do is implement those things.
Seems like it might, don't have the information, might create a lot of unnecessary anxiety in some patients too. I mean, do you really want to know that you're likely to get dementia? Or, I mean, I could create a whole bunch of anxiety-related, depression-related symptoms if you have this information.
It can, right? That's why it's not the way that information is presented to the patients in the patient portal, and the way it's presented to their physician is different. So in the one sense, it's meant to prompt a conversation, and in the other, it's meant to actually help the physician direct where we go with this patient. But it definitely can provoke anxiety, but it can also promote good planning and better life decision making for patients.
Question, when you talk about the system and the IT and the rest of it, is this pretty much real-time instantaneous, or is there any kind of a lag to this? So that I've done my visit, I've done my thing, and I'm just waiting for it to pop up so I can kind of finalize it, or is it?
You're talking about the documentation piece of it?
Yeah.
That's pretty much instantaneous.
So it's popped and I can do it and walk out the door and I've seen the last of it kind of thing.
You have to put in your password first.
What?
Put in your password first.
It's just password.
And you have to have a new one every 2 months.
So,
Password numbers.
you wouldn't have AI have programmed all these combinations and permutations. And the more advanced it gets, the more technical it gets, and look at this evolution, that's what's happening. you have to have, seems to me, programmers that are smart enough to know this. Are programmers, are they physicians that are trained, or, I mean, how do you get, how do they know all these things like genomes and genetics and, where do you get these guys?
Again, for the different products that are out there, I mean, we've covered a variety of AI applications. And so when there's a new vendor producing a clinical solution to some problem, those companies tend to have a chief medical officer as well. And then depending on the niche that they're in, that might be somebody with the right clinical background.
Expertise.
Yeah, they tend not to be programmers, but they tend to help translate the clinical world for those programmers. On the documentation side, the companies will have practicing clinicians involved, whether they remain in part-time practice or they just have a history of practice. But they definitely, that's how they get that information. The actual way that the program works can be still a black box. And so even the programmers for some of these generative AI tools wouldn't necessarily be able to say exactly why the program came up with this phrasing or this documentation. So there's some unknown pieces on this generative AI part of it.
Do you find that the medical schools are embracing all of this and teaching the students? Are they coming out of medical school saying, "We got this"?
No, I think it's a little bit too early for that at the medical school level and even for residencies, but I don't have any doubt that they will. So when you talk about medical training, probably the thing that's changed the most is how much simulation is used as simulation became higher and higher fidelity. But now all medical schools and all residency programs have simulation as a huge component, and yet it's still a tiny part of ongoing practice and education in healthcare. Probably too tiny a part still. But yeah, the trainees are getting that information. On the AI tools, I think it will develop that way as well, but also dependent on the field.
Back to Bob's point, my experience is that doctors could lead, but to do the work was not their enthusiasm. So they oftentimes farmed it over to nurses, especially with compliance and that kind of stuff. The nurses sometimes interpret it, but it would just be a shade different. Mm-hmm. And so you say, well, put that shade times a million, and all of a sudden, the information that you're putting there just kind of has a funny feel to it. It doesn't feel like a doctor's visit. I don't know if you've got that piece coming back, let's audit the top 1,000. Make sure it really says what we want it to say, or doesn't put these shades in there. It's a tremendous amount of work to do that. And obviously saying you can't do that, but you hope the companies can do this who are vending this stuff and saying, we've got this. We've got our medical director, our top 10 physician consultants, and they're helping us do this. I don't want to be anti-nurse, but I've seen it too many times, but it was just shaded funny. It just came out where I would have said that.
Yeah, I understand that perspective. I agree with it. I was a history major, and so for me, what is the history is really important. And it's also very important to me that it's written the way I want to write it. And so that is part of the reason why I haven't ever actually moved towards having a real scribe, let alone an artificial scribe. It just didn't work for me because I wanted my voice in the history. But the variety of ways that people document now is very broad.
It is.
And especially as an old timer, you probably wouldn't like it because it wouldn't.
Are you saying I don't know?
I am.
Oh.
It's
Everybody in the room except for two.
It's not that you became an old timer. I just think you've always been an old
I'll carry
timer.
it with me. And that's the deal. I look, we mentioned earlier, I look for the HPI and the physical exam and all that stuff, bam, one sheet. And, having 30 sheets doesn't help me at all. And I was playing Neeraj earlier about narcotics that have been on for a long time. I get 5 pages every visit. And he said, tell them to not print it and just send electronically, and it can be in the cloud someplace. But it's so easy to generate so much information that I hope that this says, okay, what we're gonna do, distill it down, here's the page.
Yeah.
And here's your action items.
So some of the things that the AI, the generative AI is it's interesting what it can do. It's kind of amazing in ways. So it can generate content and change the tone. So you can, I'm not talking about the tool that we're implementing at St. Luke's, right? That's different. But in general, these generative AI tools can be prompted to be more empathetic. They can be prompted to be more succinct. They can be prompted to provide this content in bulleted framework, or provide this as a prose narrative. So you can do all of those kinds of things. The kind of distressing thing is that you can make the generative AI score better on empathy than real humans will.
Really?
Yeah.
There you go.
So you give, so the study they did was having, medical questions posed to the AI from patients. And it was the subjects, what we're testing, not we, but what the researchers were testing was the physician, like a nurse triage.
Subtle.
and the AI, and the AI scored as well, maybe a touch lower on accuracy of the information provided, but it scored better in terms of empathy. So that's kind of scary, right?
How ironic.
Yeah.
Better bedside manner? What?
So,
I'm so sorry you're having trouble with your menstrual cramps.
yes, right. Because for us, for humans, it takes work to be empathetic, but it doesn't for the AI.
Implicit bias.
I'm interested in talking about text. I've read that the AI stuff includes a lot of graphical stuff as well, where you can tell it to draw a box and draw this and draw that. Is there any on your horizon anywhere where graphical type stuff could be a component of the medical use of AI?
Graphical
I found graphical stuff that is pretty strong. You can actually dictate, I want a three-dimensional box, blah, 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 with these characteristics, and bam, it's done.
Yeah, I don't know whether creating images that don't already exist will be an important part of how we do use it in medicine.
Well, I'm thinking, for instance, if I said, let's talk about your aortic valve disease, and it can draw me just that piece of your heart, and here's the part that's the problem. And for education, I was a drawer. I like to let's draw a little something and show you what we're talking about. I can see how that might be helpful.
Yeah.
And then you can throw that in the chart. But yeah, it's going to be interesting. It's not going to be in my time, but it's going to be interesting.
Well, so putting in a straightforward image like that, if you want to give it to the patient, it can do that.
Well, see, I don't want to give a heart. I want to say, okay, here is your valve with your disease.
That's
And
interesting.
this is what we can do, and surgically on your joint, we can do these things. And then the patient could have that.
Yeah, interesting.
It could be educational.
Yeah, it could be. It's not there. You have to. Well, today, if you want to put in the patient's valve, you need to have the picture of the patient's valve somewhere, right? Yeah, something like that. If you wanted to create a image of a bicuspid aortic valve with calcific leaflets, you may be able to do that right now. It wouldn't be the patient's valve.
If I had an ultrasound of my valve, maybe the AI could translate that to something that's a two-dimensional representation. So that
And then you could draw on the screen your intervention and have it part of the record too.
It's not that kind of technology isn't that far away. But
But
I encourage you to do that. I mean, I just drew, probably half of the patients every day had a drawing of some kind.
Yeah.
Just walk them through what we're doing and how come and why. Just really, I think educationally very helpful. Much better than words. A lot of people are idols.
Thank you so much, Neeraj.
And welcome, I hope this was helpful.
Excellent.
Mhm.
It was great.
Excellent. Where's that reading form? I don't do a reading form, do a reading form. Recommendations for improvement topics.
Back when we had reel-to-reel cassette that we were, dictating into those. And I would spend hours at the end of the clinic doing that. And then I realized I was really missing out on a lot of family time. So I took a stack of charts home,
As did I.
had dinner, talked to the kids and all that, and then I would go dictate. And I was listening one time, and here's my 11-year-old daughter pretending that she's going blah 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 period blah 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 period. Just cracked me up. That's probably exactly what she's hearing.
So I did a fellowship in England and I did the same sort of thing, dictating period something, and then I've been there for 2 or 3 days and secretaries came to me and says, "What is it with you and women's menstrual?" Full stop, you moron.
Full stop. It really
That's
bothered me.
good.
Yeah.
That's good.
Yeah.
Where were you in
London at University College Hospital.
No, I did a